Good evening, this is Dr. Thomas Klein. We're going to continue with our last session, bringing you up to date on things. I want to discuss what's going on in the state of Oregon, where I used to live. It's a fun place to live, but there is this conservative element that kind of rears its ugly head every once in a while in an otherwise liberal state. And right now we have the anti-opioid people rearing their ugly heads. And originally, this state was advised by people who are known opiophobes. So I don't need to go into who they were, but there's only a small group of intensely anti-opioid users. They really want people to stop using them. Andrew KOLODNY, who was the primary consultant to the CDC during the writing of their guidelines, here's his picture, went to the FDA and said, we have evidence here that opiates are so dangerous we want them restricted in dose and length. 90-day length and 90 milligrams. The FDA turned him down. Then he went to the CDC, where they basically put those things that were denied by the FDA, which is the agency in charge of opiates, and they put them in the CDC guidelines. 90 milligram cutoff, suggesting you don't use them too long. But it's never been shown that high doses cause any more problems than low doses. And even the FDA said that. So we want to be sure that when we make policy that we're building it on facts. Opiates have side effects. So does aspirin. So do all drugs. As a matter of fact, the FDA, in not limiting the dosage, realized that everybody has a totally different biochemistry. And if there really was a danger with high doses, they would have said so. This is their job. Right now they're putting more warnings on opiates because that's their job. If they get reports, then they have to put it out there for doctors. 600 drugs have black box warnings. That's the most severe warning. So the warnings on opiates are you're liable to become addicted, you're liable to overdose, you're liable to die, on and on and on. But that's really up to the patients to decide. Humira, which is an expensive, widely used drug for rheumatoid arthritis, most widely sold drug in the world, by the way. We estimate about 3 per 1,000 people die from the side effects, but that's up to the patient. If the patient is told they have a 1 in 1,000 chance of addicting if they've never been on an opiate, it's up to them to decide. Why are doctors pulling people off, forcing them off? Because they're afraid to death. The CDC got together with the DEA, and the DEA pretty much said they were adopting the CDC guidelines, so the federal drug police become enforcers for the CDC guidelines. Well, anyway, we wanted to go talk about some more polls we did. Some asked us this question: if government policy leads to forced discontinuation of critical stabilizing pain treatment, would that be considered a type of state-sponsored torture or knowingly inflicting medical harm on patients? I was surprised by this. 96% said yes. They consider this torture. Now, when you look up torture statutes, it's a little difficult to fit it in exactly, but it's not that far off. If you purposely do something that causes harm and pain, what else is it? If you know that something that you do is going to cause pain, I'll leave it up to you. Then we asked a question, if you are looking into purposely withholding medication, suppressing pain is a form of torture, then hypothetically, if Jim hires Al to torture Benny, is Jim responsible ethically as Al? In other words, is the boss and the person doing it equally? Yes, 96%. The courts actually accuse doctors of not doing physical examinations. That's none of their business. If I do a physical exam or not do a physical exam, and then they say, well, there's partial exam, well, what is this? These are lawyers. But they do it anyway, because it got mentioned one time that that was the way a doctor, they were trying to make the case this doctor was really a crook because he never did any examinations. Well, never doing any examinations is different. Generally, doctors do an examination on first visit. A lot of times on the second, third visits, you don't need to do more examinations. So we asked in pain clinics, how many times have you had a full examination at the pain clinic on the first visit? A third. That's not everybody. No exam, 40%. So going to a pain clinic, there was no exam, yet the courts interpret that as, okay. Now, these two are important, very important. We are looking for ways to identify people with long-term painful disease, for doctors to pick up on it and not think they're all liars and trying to get score on drugs. So there are some symptoms that we're going to look at that we asked our patients about. And it is, how many of you have painful joints? There's two groups in the hyperinflammatory disease category: rare painful diseases and autoimmune diseases. These are first cousins. Autoimmune diseases include lupus, rheumatoid arthritis, Sjogren's syndrome, and on and on. Doctors don't have too much of a problem identifying autoimmune disease, but on the rare painful disease side, they have a lot of problems because they don't know what the disease is. We are publishing 077 we've talked about that's going to list a lot of the rare painful diseases. It's a big project. We're trying to hustle it up. But we were surprised when we asked rare painful disease patients, do you have joint pain like autoimmune patients do? And 90% said yes. So doctors can screen for hyperinflammatory disease by asking, do you have joint pain for longer than 3 months? Then you can put the patients in the different categories, but at that point, you've established a diagnosis of hyperinflammatory disease, which has a diagnostic number, and you can bill for it. So just the fact that a person has prolonged joint pain, it may be rheumatoid arthritis, it may be arthritis from the central inflammatory disease, or it could be osteoarthritis, which is more common. Osteoarthritis usually doesn't attack all the joints, and a simple hand x-ray can tell whether or not a person has osteoarthritis, which is a milder, long-term, not a serious painful disease, either autoimmune or rare. I want to talk to you about Oregon. I think I mentioned I practiced there for many years. My son was born there. The medical board is now trying to pass a medical board issue that all patients in Oregon be tapered below 90 milligrams and then switched over to Suboxone. Well, first of all, according to our surveys, Suboxone only works 60% of the time in pain patients. There are a lot better drugs like oxycodone. And secondly, you're going to taper every single person? I thought the CDC was loosening their restrictions. You know, Christopher Jones, the pharmacist, was the project manager for the new guidelines of 2022. Oh, no, doctors don't need to worry about the 90 milligram dose anymore. Here they are in Oregon today, April 2023, trying to pass a rule that every single person in Oregon on pain meds be tapered. And that means all the people that were on good doses are going to be on bad doses. Under treatment is a medical malpractice, negligence. So I look at my timer here and it looks like I'm about ready to go. And let's see. We're back to looking at, we do this periodically. For all of you with these terrible, painful, persistent inflammatory diseases, CRPS, central pain syndrome, fibromyalgia, blah, 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 are you receiving adequate pain to treatment? 8% said yes. 63% are getting partial treatment. That's really awful. That means you're partially helping with the pain and loss of function. But for a few more milligrams, you could have it all. Is this torture? Sounds like it to me. I can't imagine doing that to somebody where they say, Doc, you know, it's helping a little. But I had, before when I was on a full dose, I was able to drive my car and go back to work. And the doctor is so afraid. Of course, doctors did not get together and raise hell. So, with that, I'll see if I can turn off the camera with my little device.